Hi, this is Dr. Bernstein with Dr. Bernstein's Diabetes University, our edition for March 2020. Before we answer any questions, I want to remind you of my usual caveat, namely that the answers I give are really generic answers intended for the bulk of the viewers. They might not solve your particular problem because I can't get a complete medical history or physical exam or a family history. I don't really have all the information I might need, and it would take at least an entire video session to get that information. So I guess at an answer and let the viewers try to understand my logic. This has not satisfied everybody, and we've had a number of requests for more personal answers. So if I do not adequately answer your question, we now have a system where you can get a personal appointment with me, usually by Skype or telephone, but when this epidemic of COVID is over, we might be able to give personal visits. You can call a particular number that we've arranged to make an appointment for a virtual visit where I can go over your problems. The lady who answers the phone will answer your questions about how we work this out and the details and so on. The phone number that you could use is 914-705-9933. So if you need more personal attention, you call 914-705-9933, and we'll try to make arrangements to be able to help you. If Samantha does not pick up the phone immediately, leave a message, and she'll eventually get back to you if you're in the USA. If you're out of the USA, you have to call back again and try to reach her. Okay, 914-705-9933. And now to our first question. I underwent a Whipple's procedure in 1997. Whipple's procedure is a removal of the head of the pancreas. It's a partial pancreatectomy, and it's usually performed either because there's a tumor, possibly a malignant tumor in the head of the pancreas, or there's a tumor in the duodenum right next to the pancreas, and when taking out a piece of the duodenum, they take out part of the head of the pancreas. And of course, this can reduce the amount of insulin that this person can make. About 9 months post-surgery, I was diagnosed with diabetes. That you could expect because part of the pancreas was removed. They tried oral medications for about 3 months and then started me on insulin. I think of myself as a surgical diabetic, but wonder now if I would be considered as type 1 or type 2. Well, you would actually be called a secondary diabetic, namely caused by something other than the usual causes of diabetes. Type 1 diabetics usually have antibodies to parts of the pancreas or to insulin, and type 2 diabetics usually have insulin resistance, frequently because of obesity, and this is secondary diabetes due to surgery. I'm a slim 67-year-old Asian woman. My endocrinologist has classified my diabetes from has reclassified my diabetes from type 2 to LADA, that's latent autoimmune diabetes of adults. My most recent A1C was 6.1%, up from 5.8%. Currently, I am injecting 3.5 units of Humalog Jr. to counteract the dawn phenomenon from above 100 milligrams per deciliter to a max of 138 milligrams per deciliter, and an additional 3.5 units to 7 plus 7.25 units before a meal. My question, should I ask my endo to prescribe a basal insulin? If so, what would you recommend? Well, first of all, I'd recommend that you read my book, Diabetes Solution, because it will give you clues as to what you have to do to find out what types of insulin you need and when you should take it and what the dosing should be. LADA, by the way, is about equal to type 1 diabetes of adults. So you may need insulin, there's a good chance, but read the book, do the testing that it suggests. From what you presented already, it looks like you may need insulin, but I can't be sure. The long-acting insulins or basal insulins that I do recommend are Tresiba or Levemir. Tresiba probably lasts longer than Levemir. For full type 1 diabetics, we usually need Tresiba twice daily. And for many type 2 diabetics, we can frequently get away with Tresiba once daily. And the reason for considering Levemir, which may not last as long as Tresiba, is because it's usually much less expensive, and therefore insurance companies are more likely to approve Tresiba than, more likely to approve Levemir than the Tresiba. The Levemir is usually less expensive. Diagnosed with type 2 diabetes since June 2018. I think I had it for a long time. My A1C at that date was 12.7, which is pretty darn high. I think it's somewhere near a blood sugar of 300 milligrams per deciliter. Follow a low carbohydrate since June of 2018. Well, that's since the diagnosis. Since then, my A1Cs have been 6.1 and 6.2, and now 6.5. I cannot seem to get a lower A1C, even though on a very low carbohydrate diet. Well, people who go as high as you did frequently need additional medications, possibly even insulin. I cannot seem, okay, I'm 5.3 feet in height and 117 pounds. So this person is not obese. It is very difficult for me to gain weight. Just had blood work that showed my insulin sensitivity is good, but my C-peptide is low. So this person is not making enough insulin, but is not likely to be insulin resistant. Should I be taking insulin, and if so, what kind? Well, again, my book, Diabetes Solution, will give you clues as to what kind of insulin, whether you need it before meals, whether you need basal insulin, whether you need both, etc. And it tells you how to do experiments that would give you more information as to exactly what kind of insulin you need and when. Again, the basal insulins that I recommend, and again, not everyone needs basal. There's some people who can get away with just pre-meal insulin. And the basal insulins, if you need them, would be first choice Tresiba, second choice Levemir. And remember that diet does not necessarily cure diabetes. The only time I've seen diet maybe cure a diabetic was when I had a friend who was 100 pounds overweight, and he lost 100 pounds, and he was taking large doses of insulin, had become diabetic, and when he lost 100 pounds, he no longer needed insulin. Now, that was many years ago, and I think that I outlived him a long time ago, but that's the only case that may have been a cure, and that was quite a huge weight loss. For patients willing, able, and with excess body fat, would a no-carb approach make blood glucose levels more predictable until blood glucose normalizes? Well, if you're already diabetic, I've seen no evidence that a no-carb diet would necessarily normalize blood sugar, because other nutrients can raise blood sugar, especially protein. But even as I indicate in my book, a diabetic can eat a handful of pebbles and his blood sugar can go up due to what's called the incretin effect. After blood sugar normalizes, I might add a few slow-acting vegetables to get phytonutrients, not exceeding your 6-12-12 protocol. Apparently this person read my book. Note, this seems like the pre-insulin days. Does this work perhaps now in conjunction with insulin and or other medications? Well, again, there's no magic. You're not necessarily going to cure diabetes by getting rid of the carbohydrate, and getting rid of the carbohydrate for a while may only have a moderate effect or slight effect upon how your beta cells are functioning. So don't expect that this protocol is going to cure your diabetes. I always enjoy hearing more details about your personal life. We were discussing you the other day and we're curious, are you a cat or a dog guy? Well, I've been a dog guy for since I was about 22 years old when I was first married, and we frequently had more than one dog. Right now we have one dog who happens to be a mezzo or soprano or contralto, and he will sing on demand, or when he hears his favorite song by Jacques Offenbach from the Tales of Hoffmann. It's called Saint-Ile Diamant, and it's supposed to be sung by a human bass baritone, but he, as I said, is a mezzo-soprano or contralto. And I'm only answering this question because we have a video of him singing on demand. I did not make one of his singing in response to Saint-Ile Diamant, but he will sing on demand, and he has a good bel canto resonance in the upper registers, and I hope you enjoy the video. Hi, Bailey. You want to sing? Let's hear you sing. Come on, sing. Oh, yes. Oh, what a good singer. Oh, yes. Yes. Yes, you're a great singer. Oh, terrific. Oh, that's great. My 2-year-old was just diagnosed. The doctor is recommending 30 grams of carb for breakfast. That's a hell of a lot, even for a non-diabetic two-year-old. Blood sugars go up to over 300 and then come crashing down. I'm starting to understand that something is very, very wrong. My question is there anything you recommend for a 2-year-old that differs from what you would recommend for an adult or a teenager? Yes, I would recommend that the carbohydrate be reduced in proportion to the body weight. So, and also that the insulin be reduced accordingly. For pre-meal insulin, we recommend diluted regular insulin, and it's urgent that you read my book, Diabetes Solution, and that's all I can suggest, but read the book right away, and you have to find either a pediatrician or a family care doctor who will be willing to give your daughter low doses of carbohydrate and also very low doses of insulin. Unfortunately, we do not currently know how to dilute long-acting insulins, but there's an intermediate-acting insulin, NPH insulin, that can be diluted, and you would have to give multiple doses of this basal NPH in order to cover the fasting part of the day. Again, this is covered in the book Diabetes Solution. Our son is 7 and was recently diagnosed. We find the high carb recommendations insane and the roller coaster blood sugars dangerous. We discussed low carb with our endo, and her comment was that she will rebel and eventually eat carbs, so she needs to learn how to take insulin to cover carbs. What do you think? My offhand guess is that your endo is obese, but I'm not certain. I would certainly be interested in finding out what the situation is in that case. Carbohydrate is addicting, and if you start kids on carbohydrate, you are starting them on an addiction that can certainly curtail their well-being and their longevity. I'm on a low-carb diet. It's working great for me. However, I see many people on YouTube who eat high-carb, low-fat diets. They are losing a tremendous amount of weight and also have super low A1Cs. How is this possible? Well, it's interesting that I get this question right now because last night I was watching television and there was an ad on television. No, I'm sorry. I was actually playing some opera music while I was working out in the gym, and I got an interruption of an advertisement from a supposed doctor who was promoting a high carbohydrate, low fat diet and his vitamin package. And he was citing individual doctors who had advocated low carb diets and had died prematurely. And the particular doctors that he cited had interesting histories that did not support his argument. For example, he said that Robert Atkins died prematurely from his low-carb diet, where he actually slid on the ice in front of, outside his office and bumped his head and was in a coma for several days from a physical injury. So a lot of these things that you see on YouTube are phony, and I wouldn't believe them. I'm already on such a right. If I'm still producing endogenous insulin, would it be safe to cut off basal insulin entirely if blood glucose remains within the normal range after incorporating exercise into my routine? I'm 29-year-old male, body mass index 26.6, diabetic complications, retinopathy. Well, first of all, there's a possibility that excess exercise can raise blood pressure and even make certain forms of retinopathy work. So I would say that if you're going to do such strenuous exercise that you'll be able to reduce some of your insulin, that you better consult your retinologist and also your primary care doctor. There may be a hazard to this. Whether or not it will work to lower your insulin, it may or may not. I can't predict whether it would. My guess is that it probably wouldn't, but I'm not certain. But I certainly would contact the retinologist and your primary care doctor who might have ideas closer related to your situation. I follow your program and use very little insulin. I take regular and Tresiba. Is the expiration date really accurate, or will the insulin stay good as long as it is in the refrigerator at the proper temperature? A very good question. And so far as the regular goes, the regular is certainly as good as it's even better than the expiration date. Over the years, I've used regular past the expiration date, even a couple of years past the expiration date, and find that it does very well. As far as the Tresiba goes, I'm not certain. I certainly use Tresiba. I think the manufacturer warns people about not using it for more than a month after you first take the first dose. I don't think that that's valid. I think that it may have to do with their guess as to how long it lasts without actually having tested it, and not wanting to prolong the testing and still get FDA approval. They give a tight warning. That's my guess, but I'm not certain. So you can experiment with the Tresiba. I certainly would keep it in the refrigerator. I keep my Tresiba in the refrigerator. If I go out of town, I take Tresiba in a Frio bag with me. So it's not necessarily in a refrigerator, but it's kept relatively cool, and it seems to work. So I think you can experiment. And if you get any hard data, let us know. But regular certainly lasts very well. Should we be getting B complex shots regularly? as type 1 diabetics? If yes, how often? I have found in the past that it has reduced the quantity of insulin I need. Well, first of all, I have to point out that metformin, which is usually frequently used by type 2 diabetics or by obese type 1 diabetics, can sometimes reduce B12 levels by impairing the intestinal absorption of B12. Doesn't apply to everyone. We've discussed this in prior videos. So if you're taking metformin, you should be checking also your serum B12 level, and also if you're taking metformin, you should be checking your serum B12 level. If it is low, the scientific literature has shown that taking calcium at the same time as you take the metformin can circumvent this problem. Now, what about people who are not taking metformin? I routinely check serum B12 levels on new patients or on patients who show signs of anemia, and I rarely find deficiencies of B12 in any of my diabetics. So I would suggest that if you're worried about B12, that you see a hematologist and let him evaluate the situation. If you find that it enables you to lower your insulin, then I'd still see a hematologist to measure your B12 levels and determine how you should take it, whether you should take it by liquid, by tablet, by capsule, by injection, by intravenous, etc. I don't think this is a common problem. We still struggle with adrenaline spikes for my young daughter. We're away for the weekend, and it's super exciting for her, which means a lot of corrections and waiting to see what happens. What are your thoughts on children and adrenaline in the context of kids be kids? More specifically, things like water slides, roller coasters, zip lines, etc., that are sure to spike. So I guess my question is, how and when to correct? And is it more important to maintain stable blood sugar and therefore avoid these activities, or let the child have the experience knowing that it is not the norm and eventually she'll come down? Well, there are several things to think about. First of all, if you have evidence that she's still making an insulin, and our videos tell you how to determine that, if she has frequent elevated blood sugars, high serum glucose levels do destroy beta cells, and we want to preserve her beta cells. It is much easier to treat a person who has remaining beta cells than it is to treat a full type 1 diabetic like me who has no more beta cells left. Much harder work. So that's one problem. It is frequently possible to prevent the spikes by giving the patient a beta blocker that stops the effect of the adrenaline, maybe turns off the adrenaline. And we've used it on both children and adults, many children. We usually start with a small dose, 5 milligrams of propranolol, and in some cases, larger kids, we may give 10 milligrams about an hour before the event. I just got through speaking today to the mother of a daughter who's a ballet dancer, and she takes lessons every day. Last year, she had one teacher who was mean to the class, and when she had this teacher, her blood sugars would go up. So we gave her propranolol an hour before the class with this teacher, and it did the trick. We also use propranolol for kids before they have competitive ball games. Again, many of these kids do fine when they're with the home team practicing, but they have a competition and they get very anxious and their blood sugars go up, and the propranolol frequently helps. So that's a possibility. I think that it is very important not to have high blood sugars. There's much evidence out there that the brains of diabetics with higher blood sugars do not mature as normally as in kids who have normal blood sugars. My daughter is completely flat and steady until she wakes up and then starts to rise. I have given up to 3.5 units of Humalog, and she still spikes to 137 before she comes down. What can we do? Well, the first thing I would do is get a continuous glucose monitor, because if you are more aggressive at trying to prevent the dawn phenomenon, which appears to be what's happening, you're also increasing the likelihood of going too low. And you might want to set an alarm on your iPhone to wake her up a few hours before awakening to give her some kind of insulin. Question is, what insulin should it be? It might be just a small dose of regular insulin. For example, if it takes 3.5 units to bring her down, maybe if you gave her a half unit 3 hours before the rise, it would do the trick. Or maybe even, and if you have a continuous glucose monitor, you'll see on its display just what happened to her blood sugars after she got a half a unit, or a quarter of a unit, or a diluted unit. It's all trial and error, and I'm just hopefully pointing you in the right direction, but that requires some experimentation. Whenever my 13-year-old daughter goes to sleepover, her blood sugar spikes up from normal to about 185 overnight and results in a sticky high. She tells me she doesn't eat anything that would cause this. Can you explain this and give suggestions how to prevent it in the future? I want her to be able to have this fun, normal childhood experience while maintaining normal blood sugars. Well, first of all, I would suggest that you and your daughter read my book, Diabetes Solution. Secondly, that she get a continuous glucose monitor so that you could see when she stays at a friend's house, when the blood sugars go up. I just had a young patient whose a friend's mother takes her home from school and feels sorry for her that she's on such a low carbohydrate diet, and gives her blueberries in the car when she comes home from school. And for months we were wondering why her blood sugars are always high when she gets home from school. We finally found out why. So you might have to investigate that more carefully. But another option is to have the sleepovers at your house, where you can actually see what's happening and what the kids might be eating, because her friends might be slipping her candy or other sweets. And that's a very commonplace situation with friends of diabetics. So one good experiment would be to have all of them sleep over at your house. Also, she should keep a glucograph form. She's 13 years old, and write down whenever something occurs that might raise her blood sugar. Now, the last option we've discussed several times in this video, namely, if it's the excitement that raises her blood sugar, you could consider using propranolol, but that's not a certainty yet. Let's see what happens when they stay over at your house. I am tired of the cholesterol talk about my son's labs. Anything I can give the endo to make them feel better about his numbers and make them realize that he will not need a statin earlier than most people? Well, there are a number of articles out there in the scientific literature. I think I have one. There are actually two from the Journal of the American Medical Association that I just was looking at today that relate to the funding of reports that perpetuated the cholesterol myth, the funding by food makers. And they actually list the names of the makers, Nestle, General Mills, and a variety of manufacturers who make high carbohydrate foods that are funding researchers to publish phony research. And we now know that the major precursors of coronary artery disease are inflammation and high blood sugars, and that eating fat and having elevated cholesterol doesn't seem to relate. We do know that there are risk factors that you could measure in the blood other than cholesterol that do correlate with subsequent coronary artery disease. And these are mostly inflammatory risk factors like C-reactive protein. But a very potent one is lipoprotein small a. Triglycerides, which go up when you eat carbohydrate, are significant, is a significant risk factor. And we've listed many of these risk factors on my prior videos. And again, you could recall the articles that I've cited in the past, including those by the American Medical Association, that show how the cholesterol myth has been funded by food manufacturers. And you could ask your endos if they're being funded by food manufacturers, sweet food manufacturers. Please tell me about electrolytes. I track my potassium intake and magnesium intake, and they both seem low. Sometimes I feel muscle cramps, and they resolve with adding some supplements. Do you typically see this in patients? Well, to be objective about this, I would suggest that when you have periods with muscle cramps, you get blood levels drawn. You could, if you get a metabolic profile, it will show you your serum potassium. You could also order separately a red blood cell magnesium level, and if when you're getting these problems, your potassium or magnesium are low, you could try supplementing. Consult your doctor. There is a good source of mixed electrolytes, which I give to patients who have diarrhea and are actually losing electrolytes. This is one of many brands. It's called Powerade Zero, and I'm illustrating it right now. It tastes good, and it's got a mixture of electrolytes in it. I don't recommend that people go around spending their lives drinking Powerade Zero, but it does taste good. No sugar, no calories, but get the blood levels first. And if you have sicknesses where you have diarrhea or vomiting, it's certainly a good idea to consume electrolyte solutions like this. And that's in my book, by the way. I've noticed a change in my daughter's behavior, especially when her blood sugar is high. It's like she becomes a completely different child. Does this behavioral change mean the complications are starting? I'd suggest that you read my book, because we have comments at the beginning from, I guess, about 13 different patients telling how terrible they felt when their blood sugars were elevated. And for the first 30 some odd years of my diabetes, I was walking around with very high and very low blood sugars, not knowing what they were. And I certainly felt wiped out, depressed, chronically sick. In fact, when I would come home from work each night, my wife would ask me, "How are you?" I'd say, "All washed out." And she'd say, "You look it." And that would be every day until I started getting my blood sugars controlled, which was after I invented blood sugar self-monitoring. A few years ago, you mentioned some news that the blood-brain barrier contains pericyte cells which get damaged due to high blood sugars. Any news or progress in this science? Well, I didn't discover this. This was known since the 1970s. There's no new news about pericytes being what are called aldose reductase cells. I believe it's mentioned in my book, Diabetes Solution. There is some evidence now that there are other cell types besides those mentioned in my book that are destroyed by high blood sugars. I believe that these may be glial cells in the brain, which are repair cells, or etc. But as far as the pericytes go, we pretty much have known this for a long time, and the fact that pericytes line the capillaries that isolate the brain from the central blood circulatory system is not a guide to a cure or anything like that. I track my macronutrients very carefully. I notice if my dietary fat intake goes up, then my insulin requirement goes up. This also happens inversely with exercise. I think this is an important piece of the puzzle when trying to get basal daily dose consistent. Any comments? Yeah, read my book, Diabetes Solution. It's all covered in there. Although the ADA has for years claimed that only carbohydrate raises blood sugar, ever since any of us have been measuring their own blood sugars, we've been aware of the fact that any food that goes into your intestines is going to affect your blood sugar. And as I've mentioned many times, in type 1 diabetics, even eating a handful of pebbles can raise your blood sugar by distending your gut. Well, that's it for March 2022. But let me remind you again that those of you who have not had adequate answers and want to do private consultations, you can now make appointments by phoning me or my appointment maker at 914-705-9933, 914-705-9933. Our next video will be on Wednesday, April 27th, 2022. Look forward to seeing you then. Good luck.